Hello, everyone. So this station is regarding inflammatory bowel disease with pregnancy. So this is a structured Viva task assessing communication with colleagues, patient safety, and applied clinical knowledge. You are the registrar in the antenatal clinic today. You have seen Hannah John, a 32-year-old who came today for booking. She is 17 weeks pregnant and she's taking medications for ulcerative colitis. The examiner is going to discuss with you regarding the management of her pregnancy care. So first thing, we need to know why she came to book her pregnancy at 17 weeks. So we consider her as a late booker. We have spoken about the late booker in another video. So we need to explore why she didn't come earlier in her pregnancy. Now she has missed her dating scan. She has missed the screening tests, the normal screening test, routine test during booking visit. So we have to do all of that. However, she will not be able to do the combined test for Down syndrome. So we need to put on our mind that she will need a quadruple test. Okay. So first of all, we need to explore why she's a late booker. Okay. And she's on medication for ulcerative colitis. We need to know what kind of medication. Usually, the main concern of this medication is one of the biological treatment called infliximab. So we will talk about it in details. Okay. So what are the questions expected from the examiner in this kind of station? So first question will be, what data from the history we need to know to plan her antenatal care? So before answering this question, we need to talk about ulcerative colitis. What's ulcerative colitis? So it's a chronic condition or long-term condition with unknown etiology, but most probably it's an autoimmune disease. So what happens in ulcerative colitis is the immune system, possibly there is a theory that the immune system is attacking the bacteria in the bowel, in the colon, okay, in the large intestine, as if it is non-beneficial bacteria. So it causes inflammation in the colon, and this inflammation, when we have any part of our body inflamed, there will be some exudate, like fluid exudate. So the patient will develop diarrhea because the fluid in the bowel will increase. So she will have diarrhea. It can also produce pus if they, if the white blood cells attacking the bacteria, so pus formation can be formed. So the diarrhea may contain pus and ulceration. So it can even attack and destroy parts of the lining of the colon. So the ulceration can be small ulcers or big ulcers. So there is a possibility that the diarrhea contains blood as well. So, and because the inflammatory process is going on in the whole colon or large intestine, the patient will develop abdominal pain, will develop fatigue, and also weight loss because she is losing her nutrient without being really reabsorbed. Okay, so these are the symptoms. How severe is ulcerative colitis? It's variable in severities because it comes in like phases of flaring up and phases of remission. So sometimes the flaring up may be just mild symptoms, and sometimes it may be horrible symptoms that may necessitate admission to the hospital and may necessitate surgery to remove the affected part of the bowel. How long does it last? If she got remission or flare up, it's also variable. Sometimes it may just last for a few days of flaring up. Sometimes it may last up to few months of flaring up. So what are the triggers that cause flaring up? There is no specific trigger known for flare-up of ulcerative colitis. However, it's believable that it may be stress, okay? So we really don't know like the trigger of hair flaring up. So usually what kind of treatments these people will be on? So most common type of treatment called aminosalicylate, like sulfasalazine, which is quite safe in pregnancy. There is no concern at all. However, it's antifolate. So if the patient is on sulfasalazine, we need to ensure that she's taking high dose of folic acid, which is 5 milligram during her first trimester. But this patient unfortunately came after this period. So when we ask about her, like when we talk about that, we need to confirm whether she took folic acid or not if she's on sulfasalazine, okay? The second group of treatment they need is corticosteroids. You know, this is autoimmune disease and at the same time inflammatory condition. So the corticosteroids will act on both sides. It's anti-inflammatory effect and also it causes immunosuppression. So corticosteroids like prednisolone is quite safe in pregnancy. We can give them. However, there is sometimes increased the risk of having cleft lip and palate for the baby. And to rule out this risk, actually, we need to go for the 20 weeks anomaly scan. Bear in your mind, if the patient is taking corticosteroids for more than 4 weeks during her pregnancy, we need to arrange hydrocortisone in labor, like IV hydrocortisone in labor. So anyone, any lady, any pregnant lady who is taking regular corticosteroids in pregnancy for more than 4 weeks, she needs IV hydrocortisone in labor, okay? The third group of treatment they are on is immunosuppressive, and that can be azathioprine, which is already safe in pregnancy. We give it during pregnancy and breastfeeding with no concern. Some ladies may be on methotrexate. So methotrexate is not safe during pregnancy. We need to stop it at least 3 months before pregnancy. And also we need to put her also on high dose of folic acid early in pregnancy, okay? So we need to be sure that she's not on methotrexate. Otherwise, we need to stop it as soon as possible. The last group of treatment, and that is the debate now, is biological treatment. So one of the drugs called infliximab. Infliximab is a biological therapy or one of the monoclonal antibodies and a kind of immunosuppressive, which is given to decrease the severity of flaring up. And there are some concerns with infliximab. I will talk you about when we are answering the questions, okay? So let's answer the first questions. What data from the history we need to know to plan for her antenatal care? First of all, we need to know whether this pregnancy is planned pregnancy or unplanned pregnancy. If it is a planned pregnancy, we need to be sure whether she's already talked to her gastroenterology or bowel doctor regarding her pregnancy or no, and whether she's put on the safest medication during pregnancy or no. Because if she's on methotrexate, she should not continue the methotrexate. If she's on sulfasalazine, she should use high dose of folic acid, as we mentioned, okay? So if it is unplanned pregnancy, we need to know what kind of medication she's on, and we need to stop the unsafe medication as soon as possible. And we ask her like if she's happy to continue the pregnancy, because some patient may be like unhappy to continue the pregnancy, and that's why they came as a late booker. So that's one of the things we need to ask. And then we need to ask about whether she got pregnant during a remission phase or a flaring up. What is the difference? So if she's pregnant at the time of remission, the risk of flaring up during pregnancy is very minimal, okay, is about 30%. So she may go through the pregnancy without any problem. However, if she's pregnant at the time of flaring up, that put her at risk to spend the whole pregnancy period in a flaring up thingy, okay? So that's the second question. So first question, is it a planned pregnancy or no? Second question, whether the pregnancy happened during the flaring up or remission period. And the third question, what are the symptoms she's having right now? If she's having any diarrhea, any pus in the stool or bleeding, blood in diarrhea, whether she has abdominal pain, fatigue, and also we need to rule out any nutritional deficiencies like B12 deficiency and iron deficiency as well. Okay, so that is the third question. And then we need to ask about her medications. What are the medications she's taking? If she's like, usually she will be on infliximab. The problem for infliximab, if the patient is planning to get pregnant, we need to stop this medication 6 months before getting pregnant. However, if she get pregnant on it without stopping, we aim to continue infliximab until we start the third trimester. So infliximab can be used during first and second trimester if the patient is already on while she's pregnant. However, if she planned her pregnancy, then we need to stop it 6 months before getting pregnant. So she's continuing in infliximab at the moment, so we will not stop it now. We need to continue and we'll stop it at the third trimester. Why we stop it at the third trimester? Because they found the risk of placental transmission of the medication from the mother to the baby is very high in the third trimester. So we will continue it until the third trimester and then we'll stop it, okay? And then she will resume it after delivery. Okay, we need to ask the normal questions as any antenatal care, like what is the last menstrual period if she remembers, and if there any concern at all regarding her symptoms or anything. And the most important question here is the surgical history, because one of the treatment in severe cases is to do surgery to take part of the colon or even the whole colon out. And some patient may have repeated surgeries. So we need to ask if she has any history of bowel surgeries before or no. And that's because we need to know if we, like, because if sometimes she need a C-section and she had a previous repeated surgeries, we expect adhesions inside, and sometimes we may need a colorectal surgeon to be present if she has a severe or massive surgery. Okay, so as normal, we need to ask about allergies. Also, family history is relevant here because these inflammatory bowel diseases run in family. There is a possible genetic thingy. So these are the most relevant thing in the history. So what are the effects of pregnancy on ulcerative colitis? So, pregnancy is one of the immunosuppressive conditions. So it suppresses the immune system of the body. So usually if the patient is in remission while she's pregnant, is most probably it will remain in remission. Is a possibility of having a flare-up during pregnancy is minimal, is about 30%. However, if she got pregnant while she's flaring up, the risk of having a flare-up during pregnancy will be higher, like around 66%. And you know, it will, because of the pressure of pregnancy on the bowel and displacement of the bowel, and these kind of things will increase the abdominal pain, will increase her symptoms, diarrhea, and bleeding per rectum as well. It also affect the treatment. So if she's on any treatment, we need to modify to more safer option. And also there is a risk of possible intestinal obstruction if the pregnancy is increasing and displacing the bowel. So we need to follow up her carefully. Okay. So what is the effect of ulcerative colitis in pregnancy? So as I told you, this patient will have lots of abdominal pain, malnutrition, and fatigue, and also the nutrient factors will be less. And because this is autoimmune disease, the risk of miscarriage, the risk of preterm labor, and risk of small for gestational age baby will increase in ulcerative colitis. It's also, we need to remember one important thing is the VTE risk, because inflammatory bowel disease are one of the major VTE risk factors. So if the patient doesn't have any other risk factors for VTE, she will need antenatal low molecular weight heparin from 28 weeks and also for 6 weeks postnatal. However, if she has any other factors, we need to consider. So we need to assess her VTE risk on the booking visit and deliver the low molecular weight heparin according to her risk score. Okay, so the second question, how we are going to plan her antenatal care. So she's now 17 weeks. She came for booking visit today. So she will need all the screening tests we need in early booking visits. So we'll take her bloods today. We'll do full blood count. We'll do the virology screening, and also we'll screen her for the thalassemia and sickle cell anemia. We need to do a urine culture, and then we'll book her for the scans. So she missed her Down syndrome screening, which is a combined test. So we can offer her the quadruple test. Okay. And also regarding her scans, she will need more frequent scans and more frequent visits. The antenatal care for any high-risk patient will be in a consultant-led unit, will not be in a midwifery unit. So her antenatal care should be in a consultant-led unit with a multidisciplinary team. This multidisciplinary team will be consisting of a senior obstetrician, gastroenterology doctor, and medical team, and also colorectal surgeon. Okay. She will need more frequent scans. We'll start with the anatomy scan at 20 weeks or from 18 to 22 weeks. And also she will need serial growth scans because her baby is at risk of small for gestational age. So she will need serial growth scans until 36 weeks. And then coming to plan for her delivery, usually we aim for vaginal delivery unless otherwise indicated. If she has a very severe bowel disease, like, you know, like if her condition is very, very severe and we can't control with the medication, then we may aim to deliver her early, okay, for us to proceed for the treatment for ulcerative colitis. However, usually there is no indication for early induction for ulcerative colitis. But specifically for this patient, because she's late booker, we aim to induce her at 40 weeks. So any patient who is late booker, the induction at 40 weeks. Why? Because she missed her dating scan, and she may tell any date for her last period. We are not sure when was her last period. We are not sure about her EDD. So usually we don't tend to leave them post date. So we will induce her at 40 weeks just because she's a late booker, not because ulcerative colitis, okay? If a patient was having lots of surgeries before and we expect that she may have a very difficult surgery in case she needs a C-section, I think the best option is to plan a C-section because if we know when she will deliver, we can assign a very specified, highly skilled obstetrician along with the colorectal, and it will be a planned surgery as well. But the decision depends on individual basis, so we can't we can't generalize the rule and tell that if she has previous repeated surgeries we aim for C-section. That's not true. It's just in case if we think that she most probably will need a C-section, then the best option is to plan it rather than waiting for emergency and unplanned. The thing related to delivery as well, if she's going for normal delivery, we mostly try to avoid doing episiotomy as much as we can, because there is a risk of perianal disease, or the inflammation may extend to the rectum and anal canal as well. So also, if she has already inflammation at this area, the risk of extension of the tear to involve the sphincters is higher there. So we don't aim to do episiotomy unless indicated. Usually it's actually is not a routine thing in UK to do episiotomy. So if she's on infliximab, she stopped taking it at third trimester, and then she will resume it after delivery. Is it safe in breastfeeding? Yes, it's safe. However, so she can take her medication after delivery. However, we need to notify the GP. For what? Because the babies who are exposed in utero to this kind of medication are likely to get anaphylaxis to the live vaccine. So we need to notify the GP and write down about looking after the baby if he's going to have the vaccination, the live vaccination. So because this medication may cause this baby to be highly exposed to anaphylaxis during live vaccines. And we need to advise her, like for the next pregnancy, to plan her delivery, to plan her pregnancy, and ask advice as a preconceptional visit, because that will put her in a safer option and safer pregnancy. Okay, so that's it. Thank you.